Hi, everyone. Good afternoon. Thank you so much for joining us. My name is Ayesha Kazim, and I'm with the Liver Coalition of San Diego. And again, we thank you so much for joining us for today's learning exchange. We're able to bring this to you today through the Eliminate Hepatitis C San Diego County Initiative, and that is a public-private partnership to help eliminate hepatitis C by 2030. This process was started in November 2018 when it was approved by the San Diego County Board of Supervisors. And on January 1st, 2022, the County of San Diego contracted with the Liver Coalition of San Diego to serve as the convener of the partnership. And now I will turn it over to our moderator, Andrea Tomada, who will introduce our topics and speakers today.
Hi, good afternoon, everybody. My name is Andrea Tomada. I'm with the HIV, STD, and Hepatitis branch of Public Health Services here for the County of San Diego, Health and Human Services Agency. And I'm a health program and planning specialist working as lead for the HCV elimination efforts. I want to thank our convener, Liver Coalition of San Diego, for hosting this in this forum. So I appreciate that. And before I present our speakers today, I'd like to go over a few housekeeping items. So one, please make sure that you mute your microphones so that we do not interrupt the speakers while they're speaking. Two, we will be doing a screenshot of everyone on the call. This is for social media purposes, and if you do not wish to be off. All right, and then also I would like to remind you that we will be recording this meeting and we will have it posted on the Liver Coalition's webpage, or sending it out and then also having it posted on the webpage at a later time. So before we get started with the speakers, I'm going to ask Ryan, do you think you could help with the screenshot?
I am happy to. So if you would like to be part of this screenshot, please turn on your video just for a second, so that we can show social media, the great participation for the awesome, great to see everyone for this learning exchange. And then of course, you're welcome to turn yourself right back off. And we will, of course, edit out names because we'll assume that you would prefer not to be on social media. So I'm going to do this right now. Everybody look very happy. Okay, thank you, everyone. And now we will move on.
All right, thank you, Ryan. All right, so for our first speakers, we have two speakers. We have Jordan Akerley, who's the strategic director for INHSU San Francisco. And we also have Ryan Clary, which you just met. He's a consultant for special projects, and he works for the Liver Coalition of San Diego, as well as working with San Diego for INHSU San Diego. But we'll go ahead and give the stage to Jordan, and he'll be giving his presentation. And many of you are aware that this is for the INHSU's recent presentation that was given on Intervention Implementation Symposium back in November 2nd. So thank you so much, Jordan, for being here and giving us the updates and highlights of that meeting.
Absolutely. It's my pleasure to join today. I've never been to San Diego, but I'm very grateful to have made a couple of cameos in the Learning Exchange platform series here. So I'm going to go ahead and share my screen. And I also do a little bit of introduction here after I cue this up. All right. And is everyone able to see the PowerPoint here? Okay, fabulous. So like Andrea said, my name is Jordan Akerley. I'm the strategic director at NHEP-CSF. Been in my role for about a year, but I've been a part of NHEP-CSF since its inception in 2016. I have my long career in mostly HCV and HIV navigation before I sort of moved through management, managing some HIV services and Hep C programs. So I've been working on hepatitis C for a long time. I want to give a little bit of background. I know that folks in San Diego are probably very familiar with our work in San Francisco, because I think we have a bit of a handshake in terms of how our, I think that maybe the development of our elimination initiatives. And I want to draw a little bit of attention to sort of NHEP C and our format, because I think it's really important in terms of how we sort of entered into and collaborated with the INHSU staff for the symposia. And I think that that might be instrumental in understanding how other cities, particularly cities or jurisdictions that are in different places with elimination initiatives, might best sort of work with, collaborate, and leverage the resources that INHSU is able to provide through this symposia. So to start off, NHEP CSF, we are a hepatitis C elimination initiative based in San Francisco. We started in 2016, and organizations and individuals are able to sign on to our work. We use a collective impact structure to organize our work. We have lots of experts who lend their time, and for many of whom, the hepatitis C work is only one facet of the roles that they play in their organizations and agencies. So to most effectively leverage their expertise, we use these 5 tenets that you see in this lower left-hand corner of the screen. That's a common agenda, setting that together, using common progress measures to measure our work, to see how we're doing on HCV elimination in sort of prioritized areas. We try to do mutually reinforcing activities across our work groups, which I'll speak to in a second. Continuous communication is a really important part of this, just lots of chatter between the groups, making sure that folks are on the same page and that we're able to efficiently share information to support the work and the action items that of other work groups across the initiative. Again, these are folks in lots of different domains, so it's really important that other sort of policy changes are really going to be most effective or impactful for the folks that we aim to serve. And then we use backbone support. So as strategic director, I'm part of the backbone of NHEP CSF, along with several other folks, and I try to describe it sometimes as running air traffic control for folks that are doing lots of important work in different spaces, and make sure we're doing that as effectively as possible to, again, produce the big impact for community. So on the right-hand side, I won't spend too much time here, but we have 4 different work groups as part of NHEP CSF. You'll see those in orange. That brings together researchers, frontline staff who are doing harm reduction work and testing, treaters, and the other folks who are providing hepatitis C treatment, and then also policy and advocacy work. And we have representatives from each of those work groups participate in our coordinating committee to help to support that continuous communication across the work groups. We also have a strong community advocates program. We have a peer of folks with lived expertise, part of our peer navigator program. And we have an executive advisory committee, which in some ways kind of functions like a very large board, hepatologists, folks from lots of different spaces, and pharmacists from different hospital networks in the city. And we convene that group maybe once or twice a year to get really specific insights on the priorities that we've set from folks who kind of have a different vantage and who often don't necessarily have time to attend monthly work group meetings. So I belabor that point about what NHEP CSF is, because I think it's really important, because we have a pretty well-developed hepatitis C elimination initiative in San Francisco. So while we're really excited to work with INHSU, I think that having a hepatitis C elimination initiative that has been around for a number of years puts us in a sort of a unique position in terms of how we stepped into and worked with INHSU to develop the symposia. I would just put up our values and mission values and strategies here for folks to take a glance at. All right. And again, this is just sort of a pop out of our structure that you saw before in a different graphic, but I wanted to highlight this community navigator program. Again, this is folks with lived expertise. And this was, I raised this because there was a significant focus on peer support programs at the INHSU symposia. And I think it's, I know that there's been work in San Diego to do that as well. All right. So just to start off, just a little bit of logistics. So I think this is important as you think about busy folks working with an external organization to develop a really important educational seminar and space for sort of relationship building. I want to really tip my hat to Scott Sukow from San Diego to really focus. This is why we were really able to host this in San Francisco. Scott keyed me into conversation with program staff at INHSU. This history of the symposia for INHSU is that they had not, prior to this year, brought it to the United States. So as many of you who are working in the field probably know, there are many countries with sort of socialized medicine that seem to be head and shoulders above the United States, especially if you've glanced at the CDC progress report for HCV that came out a couple of months ago. We know we're kind of headed in the wrong direction, and we know there's some countries globally that have done tremendous work to really focus on national elimination plans that have seemed to have been quite effective, such as Australia. So we started this conversation actually back in May, and the initial planning with the INHSU staff got underway in June. Again, this was mostly via email. Folks are working in different time zones, and we did kick off with a live Zoom session. I think it's a bit unique that we have a hepatitis C elimination in San Francisco, and that we were able to that they were willing to speak directly with me and my colleague over at the health department. What we really did at this initial stage was try to make sure that we were queuing up the key stakeholders who we felt like could help to inform the shape that the symposia would take, and to make sure that lots of perspectives, again, from different sectors were in the room. So that's researchers, community, advocacy, and other folks who work in policy, and folks who are on the front line who are implementing a lot of the interventions, be that outreach and navigation with folks in community. So that from June to August, because these folks are very, very busy, we spent a lot of time doing those introductions with local stakeholders, kind of setting kind of reminders in our calendars to follow up with folks who we know are very busy during summer outages and so forth, and really focusing on doing like a warm introduction between the INHSU staff and those stakeholders. And I know that might seem very simple, spending time on, but I think this is critical, that I was able to show up and I was able to have a conversation with someone ahead of time to make sure they were aware of the opportunity, and that I was making the introduction and really positioning folks to be able to leverage input. I think that was particularly really important for us to do with community and folks with lived expertise, to make sure that they that the format that they were being outreached in, be that email or Zoom or so forth, really worked for them. Then from September to October, we had a lot of conversation, discussion, and feedback about a proposed agenda. And I think as I'll speak to in a moment, and as Ryan will probably share about the INHSU's toolkit, this is a really well-developed toolkit that has clearly, they've spent a lot of time investing in this, and we know that we actually really reflected that we've had a lot of our own expertise in San Francisco, particularly about our local context. We really wanted to make sure that this opportunity, this symposia convening, was optimized for the challenges that we're facing in our local environment. We also continue to do strategic outreach to promote this symposia, because we realized folks were really busy, and actually getting together off Zoom, going to a space where it requires travel at a day-long symposia, is quite an investment for our stakeholders and for all the folks that maybe haven't been called in on our Hep C elimination efforts in San Francisco. So we really wanted to make sure we cast the net far, and that we did that, that we were very persistent, and really tried to support folks to attend. In November, up until the date we held the symposium, we were working on just sort of final agenda revisions. And again, I flagged this because it was an ongoing conversation. It required, I think, a lot of back and forth for us to feel really confident about it in San Francisco, and make sure that it was really going to be useful, because we're asking our networks to show up for 8 hours. It's a huge time commitment for folks doing this work. Just to talk a little bit about the structure of the symposia, I think it was very interesting. They were focused about 2/3 of the time on small group conversations. So we had some large group conversations. We're talking about, this aims to accommodate about 40 to 70 people. I think we had about 45, 50 people, though we had quite a few more registered for the symposia. So we started off with large group sessions, lots of level setting, and I'll talk about that in a moment. And then we really moved into these round robin presentations. I thought this was a really rich part of the INHSU's format for the symposia. And then we did small group workshops as well. So there was a lot of large and small groups. I think it's really the size and the capacity is really has been well developed by NHSU to make sure that this isn't just sort of a sit back and cruise like research workshop or a conference workshop. This is really about activating folks and having them in conversation with one another. And then we capped it off with a conversation about local resources, which we thought that was really important, because to use every opportunity possible to underscore the work that we've been doing in our elimination initiative, and to make sure that folks have access to the resources that are going to, and the relationships that are really going to enhance and expand the quality of the interventions and the work that they're doing with community. In terms of what this actually boiled down to in terms of topics, for folks who've had an opportunity to peruse the INHSU implementation toolkit, there's a lot there, and I know Ryan will give some insights into that as well. We really focused, so all of the speakers that participated in the symposia were connected to the INHSU staff by myself or my partners at the health department or other stakeholders. So we kind of crowdsourced lots of information about who are the local experts, who might best be able to connect with participants, attendees about this. So we really just got down to basics of epidemiology of hepatitis C, and we really cast the net far. So this covered everything from epidemiology of Hep C to also talking about things like some research studies. We talked about models of care. We talked about care navigation and peer support. And we had a wide array of folks in the room. So I think it's really important to hold how a broad audience might receive these things. Some of these were more heady topics and were not as accessible, I think, to everyone in the room, just because folks were working from really different places and areas of expertise. So something to keep in mind in terms of setting up attendees for the best possible outcome and use of information here. I think something that was really important was that there was a huge amount of information that was relayed about testing options. So I know that's something we're kind of waited with bated breath in the United States for whether or not, we're going to have expanded if it's going to be an investment in dried blood spot testing, and also the status of point of care antibody testing. So they did go total nuts and bolts of all of these different testing modalities and what might be coming down the pipeline, what's coming out of the pipeline. And I think that was really important, and it was a really critical piece that a lot of our attendees said that they were interested in. And it also served to make, it was a bit of a downer in some ways when you realize how far the United States is behind and how much opportunity there would be if one of these tests became widely available, and we had also the resources and the capacity to scale up dried blood spot testing or something to that effect in community-based settings. I just wanted to spend a moment talking about the round robin, because I think this is a space where NHEPC and our partners at the health department had a lot of conversation with INHSU about how we can best reach our audience and speak to the challenges we are facing in San Francisco. This was something we modified. INHSU has their own, I guess, like pre-batched topics and areas of focus. And for us, we really wanted to focus on HCV care navigation. I know navigation is a hot topic in the United States, and we also wanted to focus on provider education rather than focusing on pharmacists. So we did make some modification. We did some advocacy to modify these. I think INHSU has, again, a well-articulated and comprehensive toolkit, and we felt it was really important for us to request some changes to the areas of focus to be more responsive, again, to these challenges that we're facing. So in our settings, pharmacists play an important role. However, we really wanted to focus more broadly on provider education, something that would appeal to more folks. We didn't anticipate having a lot of pharmacists in the room, nor that it would be particularly impactful to have folks who are doing community-based antibody testing understand more about the role of pharmacists. We feel like those relationships are already in place to the extent that they're useful in expanding hepatitis C treatment in San Francisco. We really had some rich conversations. These were all led by local folks in San Francisco. I think one of something I didn't anticipate being a real boon to folks is that it really uplifted these individuals who had different types of expertise to feel confident giving these sort of 10 to 15 minute hands-on presentations in this round robin setting. These are folks who've been in our networks in our hepatitis C elimination initiatives, but really kind of honoring the work and the contributions that they had by doing these sort of small, these like mini workshops was really wonderful. We heard back from folks that was a really highlight for them. And folks went into it saying, I'm not sure that I'm the best person or that I really have enough experience. And I think it was a really impressive bit of unexpected sort of leadership development And again, sort of recognizing all of the different ways that folks show up in community and potentially modeling that for treaters, watching folks who are doing that community-based antibody testing, and pharmacists and street medicine folks watching, folks talk about how they've built and how they support peers and people with lived expertise in their programs. So that was a really phenomenal part for us. And at the same time, not all of these topics appeal to folks universally, right? So it's different than going to a conference and maybe having a track and you're choosing that. But I do think there was a lot of value in having the total exposure to each of these topics for all the attendees. I wanted to hit upon just sort of my key takeaways and reflections, but I really want to leave a lot of time for conversation and discussion. I know I'm kind of going broad strokes here, but I think the reason that I'm doing that is that I think this is about how we think about bringing in sort of a resource and particularly an educational resource and activating our networks when we know that that we can always use more education, but really this is about how do we most potentially mindfully leverage what amount to like scarce resources in our networks. So for instance, we know innovations in diagnostics are promising. That was a real clear takeaway. Folks were really excited. And we know we have to wait, right? There may be limited opportunities or things within our control, or folks, maybe who are on the front lines doing antibody testing to get their hands on dried blood spot testing. But we were able to start conversations about gene expert test is maybe coming in the future, and we know that integrating new testing resources can be really resource intensive and require a lot of advocacy. Do we want to sort of bypass dry blood spot testing? Is there an indication for dry blood spot testing, or should we kind of wait? How much might dry blood spot testing actually serve to support folks who are moving sort of through the testing process, as well as how might it impact staff? Some of the small things that came up that I thought were really interesting is we had conversations with folks who were doing street outreach and street medicine to talk about the challenges of doing dry blood spot testing for folks who just have really calloused hands. So we really talked about potential implementation challenges for these innovative diagnostic tools, and really kind of sussed out what the pros and cons of each might be, as well as how much effort might be required should these become available. One of the other takeaways here was really about integration of hepatitis C testing, treatment, and care into existing systems of care. I think that that's something we have a number of new syndemic-focused community-based clinics and resources in San Francisco, and it's very challenging for us to continue to prioritize hepatitis C in those spaces when they're trying to serve a great range of either trying to serve HIV, provide HIV care, STI care, and also just navigate benefits. There's going to be a tremendous number of things that are being asked of folks in those systems, of staff in particular, and we need to be thoughtful about how best we can integrate Hep C treatment and realize that a standalone treatment is really not going to work as effectively as we might like for the folks that we're currently prioritizing and who remain to be treated in San Francisco. And then we also need to continue to grow our networks of providers and cultivate champions, as with the pandemic and just sort of the nature of sort of the transitions in public health right now. We've got a lot of folks moving in and out of the systems that we work with, and we really need to continue to dig in. I think we met a lot of fabulous folks, got folks in the room for the symposia, and that was, this may seem very small, but to us it was, just having the one connection, but whether that's for a warm handoff, whether that's to support a new treater, or someone who has the potential to kind of hit a policy-related lever to make it easier for folks to get into test, treat, or to get access to navigation. We realize even at this stage, it's more important than ever to make sure that we're continuing to grow this network of providers, champions, and asking folks what they might need. just to kind of close out just a bit more about my reflections about how the symposia went. Again, we talked about point of care testing and diagnostics. We don't have them. We're not where Australia is, and we may not be for some time. So what might we do to expand and enhance the care, and that reduce the barriers that folks face to getting testing and getting quickly to treatment in our context? I really want to highlight that who was in the room ended up, while we had a really diverse set of registrants, this largely was folks that were on the front lines, who were doing testing, who were doing navigation. We had a smattering of researchers. It was really difficult to engage providers. I think having folks be outside of clinic for an entire day is really challenging. And I think that it's really important to have providers in the room, and in particular in conversation with folks who were doing work at sort of different spaces in the care cascade. And I think that that's an opportunity for future consideration. And I want to again highlight the importance of the local context. Again, this is INHSU has a fabulous program, and I think it's really imperative that that local folks speak to what their particular challenges are and needs are. That was something that we went back and forth in conversation with, and we're really grateful to the folks at INHSU for holding that space for us to say, hey, we could add a slide here. It'd be really important, because these are pre-developed slide decks that they offer to the speakers. So we really want to make sure that that those decks were responsive to what we have going on in our own system. For instance, we have the newly deployed syndemics focused care symposia as an opportunity to draw attention to those, to let folks know about how they can refer people in the community to access those services and what they might expect there, and sort of how that fits into hepatitis C care cascades. And we really wanted to flag also the power of providers connecting in person. I know people talk about being post-COVID or wherever we are today, and in San Francisco, we just don't have as many in-person meetings as we did have pre-pandemic. Folks were really thrilled to be sitting at a table with folks they didn't know, or for people they were reconnecting with. It was really powerful. And in a space where there's a lot of attrition, there's burnout, and we're working with a lot of different complex challenges, I think getting together and being able to connect and then celebrate achievements is really important. Whether that's congratulating someone on a paper that was published, or a promotion, or just reconnecting. I think it's really important, particularly when we were looking at where we need to go in the United States, and what's available in other countries in terms of innovations and testing and sort of the political will to eliminate hepatitis C. I think it's really important to bring local folks who are in the room back to celebrating that they're still here, that they're showing up for the work, and to being able to highlight the milestones that they're a part of, to keep people in the game, to continue to sort of solicit feedback and input about future priorities. And last, in summary here, just tips for future host cities. I think it's really important. I know San Diego in particular is focused on, where you are now, and you have your finger on the pulse. I think it's really important to be able to go into conversations with INHSU with being able to articulate a couple of the current opportunities and challenges for your context. Also having just regularly outreaching, maintaining a diverse network of Hep C providers in your jurisdiction to make sure that you're able to this isn't a cold call to draw folks into a symposia, that you're really kind of stepping into this. And I know that it takes a lot of work and resources to continue to do this, because folks are busy, trying to get folks from MAT programs in, trying to folks from the VA or whatever kind of network. I think it really requires a lot of diligence and investment. And yeah, I can't say that enough. It's all about relationships. I want to highlight communicating again with the INHSU team about local priorities. They are fabulous. This is a program that they've carried out and conducted in a number of different cities, and it's been global. And you all know your local context. And I think it's really important, if you have an opportunity to work with INHSU, to really focus on local priorities and let them know why it's important to have specific items on the agenda, or to reformat things according to your understanding of the context. And again, really creating a specialized plan for outreaching clinicians, or maybe making an active decision that clinicians don't need to be in the room, rather than just having one or two clinicians, or potentially focusing on nurse case managers or community folks who are working in the community versus at a clinic, just to make a decision about whether to make it a really targeted and robust conversation in street medicine, or if you do want to try to engage all clinicians, figure out really how to get those folks in a room during a day where they're also supposed to be in clinic. And then finally, just engage and support stakeholders to participate, give feedback, and then provide them with clear opportunities about how to key back into your initiative after the symposia. I think that was really important for us to make sure we get folks on email lists, invite folks in, thank them for their time, and then continue to build those relationships. I think it's a tremendous opportunity to do this within the INHSU symposia format. And it was very energizing for folks in San Francisco. So it required a lot of work, and they were really fabulous to engage with. And yeah, grateful for the opportunity, again, that Scott brought our way to collaborate with INHSU this year. So I know I've spoken at a mile a minute here. So here's my contact information. Very glad to chat with anyone or answer any questions, but I do hope there'll be some time for discussion. So yeah, I'll yield back.
Thank you so much, Jordan. This was a fantastic presentation, and you've left definitely some questions for me. So I'll keep that at the end of our next presentation. I'm going to go ahead and give the stage over to Clary, who will also be presenting on the INHSU Intervention Toolkit. And I think he's getting himself set up here, so.
Great. Can everybody see my slides?
Yes, we can.
Okay, great. Let me get my video up. Thank you, everyone. And I will be brief because I would love to get into discussion and questions. But I do want to first thank Jordan, one, for being, you know, such a leader in San Francisco, but in the state in viral hepatitis, particularly hepatitis C elimination, taking on California Hepatitis Alliance with Andrea, as well as their work with NHC San Francisco, and for taking the time during a busy, really busy season, as everybody knows, to share information from the symposium to this network. So thank you, Jordan, very much. And you brought forward a lot that I would have talked about, which is great, so that we can work through and get to some questions. The first thing I would like to do is to thank, so I know NHSAU is INHSU, I might be wrong about that, so I'll just say that for brevity, who, you know, developed this toolkit that I'll be talking about. So as Jordan said, some of the work in the symposium was presenting this tool kit that could be used by services who treat people, or organizations and coalitions who provide services for people who use drugs. And I just want to talk through some of the toolkit, both you know, benefits that services can receive now for how to use the toolkit, but I also want to present some challenges and some barriers that I think are really important. Jordan talked about some of them, and some ways that perhaps all of us as advocates can try to overcome those barriers. So if you have a look at the toolkit, and I will put the website in the chat, and it's on my next slide, you will see that there's a set of resources available. One of those sets is infographics that provide some profiles of innovative models around the globe. Just want to be clear, this is a global toolkit, and Jordan talked about that, I think, in their approach to, an INHSU's approach to this work. So there are models that will be more applicable domestically, and there will be models that work globally, depending on what tools are available in the United States, as well as really practical tips on implementing some prevent interventions and prevent. Really, there's been a lot of research, a lot of data, a lot of published results from research. That does not mean that this is from the United States. So again, what I would like to be clear of is that this is really focused on a lot of services that are available globally, where there are a lot of more available tools. And there are some films that provide some coverage of these programs, address people with lived experience, provide opportunities for projects to talk specifically about their programs. There's even a quiz for people to identify resources needed and a way to access all of the resources. So this again was featured at the symposium. I'm just checking the chat to see. I thought maybe people can hear me. Again, not all of these tools are available in the United States. I'm going to talk about this in a minute, but very specifically is rapid point of care Hep C testing that allows people to be tested, find out their diagnosis, and be linked to care and treatment if positive within one healthcare appointment. Talk about that later. That is not available in the United States at this point. But the toolkit was really developed to inspire global hepatitis C programs and advocates around testing and linkage to care, treatment, and this is specifically for people who use drugs, which is fantastic, a resource, particularly for communities who are at higher risk for hepatitis C. And here's the website. You click, will post that, or perhaps somebody will post that into the chat. I don't know why I keep writing focus is global, but we know that at this point. And those are the tools that are particularly not available in the United States. But I would like to talk about some other challenges. One is treatment in jails and prisons. I think we know locally, statewide, around the country, that is not as easily done as said. There are a lot of challenges around providing healthcare and treatment in the correctional system. Of course, there's a lot of injustice within the system. So just, simply providing a toolkit or resources on how to do this requires looking at those issues and overcoming those barriers and a lot of advocacy. There are a lot of recommendations around kind of one-stop shops, mobile services, harm reduction programs. I think we all know that there's very limited funding for these services, and without that advocacy needed, very difficult to implement those models. Again, it's very important and great to have these models in place, but without advocacy around funding, very, very difficult to implement. Even around, there's some toolkits around barrier or testing in pharmacies, but we all know there are barriers around that as well, regulations. Even in some states, there are legal issues, state laws that need to be worked on in order to allow pharmacies to provide that testing and linkage to care. Support for people experiencing homelessness, that is another funding issue. It has a lot of stigma related to it. Just sort of the culture around addressing healthcare and support for these communities is not as easily said and done. And so addressing these areas are really important to implement this tool. I do want to say, though, San Diego County has already demonstrated some very model programs in this area with some very limited resources. I just want to call out the Harm Reduction Coalition of San Diego County, doing amazing work with some very limited resources, providing education, support, testing, linkage to care for people who are experiencing homelessness in the county. But another opportunity, so sort of expanding that model from San Diego, I think is a tremendous opportunity. I also want to say with the toolkit, I think the toolkit provides some really great advocacy opportunities. It provides some data, information, research and real world examples. And for all of us who have gone into legislative offices to talk about the need for support, funding, legislation, policies, very often that is really important to be able to bring forward. So even that piece, I think, is really important and critical and a really great benefit for us. Kind of categorizing the interventions from care, treatment, linkage really allows for the discussions to be presented in a way that the people who are not as familiar can understand. Excuse me. The toolkit really explains the importance of meeting people where they are. And so, not developing programs to expect people to come to us for healthcare services, to us for testing services, but to be able to provide those for people where they are receiving other services. And of course, the focus on people who use drugs is critical. We all know that this is the community at greatest risk for hepatitis C. I would not be doing my work as an advocate without presenting some ideas around how to get involved with some advocacy to make sure these barriers can be overcome. There is a working group, a national working group, working on trying to bring these point of care Hep C testing diagnostics to market in the United States. And so you can contact Adrian Simmons at MVHR to try to be involved. I'll put my email in the chat. You can contact me and I can get you connected. There's also the White House Hep C elimination plan. A lot of you may have heard about. This is tremendous opportunity for the community, but just to make sure everybody knows, it prioritizes rapid Hep C point of care diagnostics, and I can get you connected to the coalition to engage in advocacy as well around that, to try to make it turn into legislation and law and get implemented and funded. There's a contact, Erica Miller is kind of leading this effort for this effort at the national level. You can get in touch with her. And then CalHep is Jordan, and Andrea is actually at the state level working on efforts to get funding and legislation and administrative policies through the California Hepatitis Alliance. And I encourage folks to get involved with that also. And that is my brief presentation, so we can get into discussion and questions.
Thank you, Ryan. While you're getting situated, I did see one question in the chat, and it was from Kathleen Swartz. I don't know if she's still in the room, but her question was, does a San Francisco program include children with HCV? And I guess that question would go to you, Jordan.
Thank you. That's a great question. So we do have a perinatal HCV working group. It's a relatively new working group. It wasn't featured on that icon that I shared during the presentation. That group is focused principally on treatment, testing and treatment of folks who are pregnant, as well as consideration and sort of uptake of the emerging information about guidelines, or what we do know and what we don't know about treatment among folks who are lactating, treatment of Hep C, as well as sort of testing and treatment for children. I know there were some new guidelines that came out just a couple of weeks ago, so that group is really focused on integrating that new information, what types of resources providers and patients may be looking for, and sort of developing those, as well as just sort of enhancing our current systems in terms of surveillance to make sure that we're actually offering sort of the best care according to the guidelines that we have in place now. I think you're on mute, Andrea.
Thank you, Jordan. It had to happen, right? At least once. I will be sure to answer these questions too and send them out if for whatever reason people weren't able to stay on the call the entire time. I'd like to open the floor for any other questions or any other additional feedback from the symposium that you would like to share. Please feel free to unmic and share that. Thank you, Ryan, for sharing your information in the chat.
I may, if there's just sort of quiet for a moment, just offer one other sort of observation that I think is, I'm not exactly sure what's happening in San Diego County, but looking across the United States and sort of thinking, reflecting on where we are in San Francisco, the socio-political climate for providing care has shifted substantially in San Francisco, particularly around serving folks who use drugs and providing high quality healthcare, and a lot of questions about the strategies and evidence-based methods of providing care, engaging folks in care. And I think we have been a bit more on the defensive in some ways in San Francisco. And I think that I just want to underscore the importance of the INHSU symposia to really to focusing on the importance of providing high quality care to all folks and really making sure that we are mindful to strategically ramp up interventions that are responsive to the needs of people who use drugs in order to eliminate hepatitis C, and that there are unique challenges in our setting time.
No, I think that's a very valid statement. I think and this is just my opinion, that there's more recognition that the traditional healthcare setting is not going to be necessarily the best route for getting care to this particular population, which is why some of our providers here in the county have opened up opportunities for them to get, that care in settings where they can be met. And so I think that's important to consider whenever you're thinking about the strategies for getting HCV testing and treatment to people who use drugs or inject drugs. And if there's any additional comments on that, please feel free to add. I think we have some people who work with this particular population. If you'd like to share your experiences, please feel free. I think I see a question in the chat. If this is relevant with your program, can you speak to any collaborations with the EDs in your area? The emergency departments. Sandra, would you like to elaborate a little bit further?
Hi, everyone. Yes, I'm Sandra in Santa Cruz County, and we have been implementing our efforts to provide linkage and navigation to Hep C. And unfortunately, our local health department, our local emergency department didn't get the bridge funding for additional STI, HIV, Hep C linkage. But we're hoping that we can still establish some form of collaboration with them, given the limited resources. But so that's where my question's coming from. I wonder if there are any models out there or any experiences that anyone can share, collaborations between EDs and local health departments or other programs around Hep C treatment. Thank you.
And I might add too that it may not necessarily be focused to HCV treatment. Maybe there's a model out there among HIV or syphilis or other interventions that are out there that could help facilitate or foster the same kind of services that we could provide for HCV. I think, and I do know of that, the bridge program, and it was surprising how many people who were interested in it. But there was limited people who were actually awarded the grant. And my question is to those who had sparked interest, what were some barriers that may have changed their minds about it? And, you know, I kind of wonder if maybe navigation was one of those reasons, because it does require a great deal of time and effort. But, you know, I'll kind of leave that out there too. And I see a response from Libby. She said, we began a one-stop shop rural Mendocino County, where we had syringe services, testing, treatment, homeless services, OUD, and HCV treatment in-house. And then I have Catherine Tuyuka, and she is saying, Sandra, one of our big hospitals got the bridge funding, and we have a webinar about in a few weeks that I can keep you posted. Thank you for that, Catherine. All right, great. And if Libby or Catherine, if you'd like to come off mute and explain any further, please feel free. It looks like Libby added in for behavioral health several years. Any further elaboration?
Hold on, I'm just trying to bring up my email
Okay.
about that. So let's see. And this is Catherine from Alameda County. So so it's important to the distinction that the health department did not get the grant because we didn't apply for it, but some of the main emergency department doctors who are really well known in Alameda County, particularly for HCV, did get funding. So 3 of them from Highland Hospital did get funding, and that's for syphilis, HIV, and HCV screening. And it's on December 13th, we're having the CDPH's putting out a webinar for all of the people who had gotten funding, along with the local health jurisdictions, so they can talk about maybe what their plans are and how we can, because we weren't funded, how we can maybe support them and what seems reasonable. Every indication is that since it's going to be opt-out in the EDs now, that it's going to put a large number of influx for HIV, STI, and HCV, PHI workers. So it's going to be adding more to their workload. But we'll see how, what if anything that their plans are and what we can do to help support them.
Thank you so much, Catherine, for elaborating on that. And I hope that was helpful to you, Sandra.
Thank you. Yeah, that is very helpful. We have been fortunate to start building collaborations and partnerships. But like Catherine mentioned, this is through the emergency department, and their staffing is definitely needing more support to be able to do this work.
And sorry, just Catherine again. It's my understanding that the funding was also to cover linkage coordinators or linkage workers directly in the EDs that would help them with that workload.
Well, if I can piggyback on that question, I'm also curious to learn or hear from others' experience around treating and supporting linkage for folks who are incarcerated. We recently learned that coverage for medication stops once folks are incarcerated. So that represents a barrier if someone is in the middle of treatment or somewhere along the way, along with other barriers. So, or it can be added to a future conversation topic too. Thank you.
This is Libby, and I just briefly wanted to say we did everything in our power to work with the local jail in order to know whether somebody who was on treatment was coming in so that we could deliver the medications to the jail and work with the nurse to make sure that there wasn't any interruption in their treatment. Did that for the HIV clients and hepatitis C clients that needed their meds.
Jump in and say this is a really important area that we've been focusing on in San Francisco. We conducted a needs assessment around treatment knowledge and around sort of the questions about our capacity to scale up treatment in jails. That it's unfunded, right? It has to be funded by the local health jurisdiction right now, in which we've been able to, there's been some will to do this and some fabulous staff, will to fund it.
Yeah.
And there's already fabulous staff who are very enthusiastic about doing this. I'm going to put in the chat just a link to CalAIM. I know I'm sure a number of folks have been tracking this. There's lots of questions. It's a behemoth of a piece of policy and like shifts and it could be really promising, right? It's going to, I don't think we're going to see anything before April 2024, and jurisdictions will have, I think, a 24-month ramp up period. But what that will mean when it comes into when there's readiness and it's fully in effect is that folks that are currently in county jails, in public county jails, will have an opportunity to be enrolled in Medi-Cal if they are 90 days from release. And as far as I understand it, through conversations with folks at the state, hepatitis C medications will be covered on the formulary. So this will out what enhanced care management is and how we might really leverage that. But I think it's something that as HCV treatment advocates, we should all be kind of tracking as closely as possible, sharing information, because it's kind of difficult to kind of pick out at this point. But I do think that it's going to be a space. There's going to be intersectional approaches. So it's going to be about trying to potentially bolster HCV knowledge and flagging the importance of HCV treatment for folks that are maybe working on different kind of transitions for folks who are justice involved. So whether that's housing or substance use treatment, making sure those folks also have the assets if they're doing that navigation to be able to link folks into hepatitis C treatment, or at least understand that that's a really important condition that folks get care for.
If there's no other is there any other questions? Because I think we're at time, and I want to thank you, Jordan, everybody who participated in this conversation. Thank you, Sandra, for your questions and for sharing, and Livy. I think this was thank you, Monica. I think this was a great information session that we just had, and unfortunately, I wish we had more time to talk more over it, but we will definitely take these questions and think about future presentations on these same topics. All right, so I want to thank everybody, and I wish everybody a wonderful day.
Thank you, everyone.